Coagulation, Chapter 27, or Chapter 18 from the book. 4 biochemical systems are included in the balanced interaction of the vascular endothelium and platelets: coagulation, fibrinolytic, kinin, and complement. The molecular components of the fibrinolytic system are plasminogen, plasmin, plasminogen activators, plasmin inhibitors, thrombomodulin, thrombin activating fibrinolysis inhibitor, fibrin, and fibrinogen. Plasminogen activators. Tissue plasminogen activator, or TPA, is primary in the vascular system or endothelial cell product. Urokinase and streptokinase are also plasminogen activators. Thrombin thrombomodulin complex activates procarboxypeptidase B, which binds to plasminogen binding site on fibrin, preventing plasmin formation. Thrombin activated fibrinolysis inhibitor, or TAFI. Plasmin, a serine protease that has the ability to degrade fibrin and fibrinogen, produces FDPs. D-dimer formation is the result of the action of plasmin on cross-linked fibrin. The primary inhibitor of the fibrinolytic system is alpha-2 antiplasmin. This inhibitor prevents plasmin binding to fibrin in an orderly fashion and is the most important inhibitor of the fibrinolytic system. Disseminated intravascular coagulation, or DIC. Coagulation response is accentuated. Normal inhibitory mechanisms are overwhelmed. Cannot stop thrombus formation. Coagulation factors and platelets are consumed. Microangiopathic intravascular hemolysis. Result of excess thrombin present with delayed or weakened plasmin response. Triggers for DIC. Activation of extrinsic pathway by tissue thromboplastin. Activation by direct activation on factor X or 2 by cysteine proteases. Occasionally by intrinsic pathway by thromboplastin. Acute DIC. Decompensated. Active hemorrhage is evident. Consumption of coagulation factors and platelets exceed capacity to increase the synthesis of these components. Chronic DIC. Compensated. Laboratory evidence of accelerated coagulation and fibrinolysis. Synthesis is balanced with consumption and destruction. Therapy for DIC. Removal of the underlying pathologic stimulus and maintenance of blood volume and hemostatic function. In DIC presenting clinically as a hypercoagulable state, it is not usual for APTT to be shortened. Primary fibrinolysis. Plasmin is formed in the absence of coagulation processes. Prothrombin time, or PT, is increased. Activated partial thromboplastin time, or APTT, is increased. Thrombin time is increased. FDP is increased. In primary fibrinolysis, the lab test that will be abnormal is the D-dimer level. The clinical conditions associated with DIC: placental abruption, trauma, sepsis, promyelocytic leukemia, cardiopulmonary bypass, immune complex disease, burns, anoxia, liver disease, and snake bites. Inactivation of factors 5 and 8 is caused by activated protein C. The primary tissue source for tissue plasminogen activator is the endothelial cells. DIC associated with malignancy can be due to tumor tissue factor-like activity, Factor 10 activation by tumor cysteine protease activity. Endothelial cell disruption by tumor invasion. Prothrombin fragment F1.2 is formed by the action of protease factor 10A on prothrombin. Clinical conditions associated with DIC include snake bites, sepsis, acute promyelocytic leukemia. The lab tests that are diagnostic of DIC are elevated D-dimers. Coagulation, Chapter 18 from the book. Fibrinogen, thrombin, and the fibrinolytic system. The word key for this chapter: acrocyanosis, blue or purple mottled discoloration of the extremities, especially the fingers, toes, and nose. Immunologic assay, measuring the protein and protein-bound molecules that are involved in the reaction of an antigen with its specific antibody. Monoclonal, arising from a single cell. Recombinant, in genetic and molecular biology pertaining to genetic material combined from several sources. Reptilase time, coagulation procedure similar to thrombin time, except that clotting is initiated by reptilase, a snake venom. Using reptilase, heparin would not affect the assay. Thrombin time, an assay that uses thrombin as a substrate to measure the time it takes for fibrinogen to be converted to fibrin. Thrombolytic therapy, using an agent that causes the breakup of clots. Overview of fibrinogen in clot formation and lysis. Fibrinogen is the principal substrate of the coagulation systems. This clotting factor has the highest molecular weight of all the clotting factors, and it is the final substrate on which the coagulation system is centered. Fibrinogen is heat labile, but stable in storage. When fibrinogen is transformed into fibrin, it marks the onset of solid clot formation. Fibrin formation occurs within minutes, partly as a result of positive feedback mechanism with the hemostasis system. Following activation, clotting factors accelerate the activity of the next factor, pushing the reaction to conclusion. Negative feedback occurs when reaction activity is delayed, a role played by naturally occurring inhibitors within the hemostatic system, used to keep the hemostasis system in check. Cross-linked fibrin stabilizes the fibrinogen molecule with the assistance of factor 13 and thrombin. The creation of cross-linked fibrin is an orderly process by which thrombin cleaves fibrinogen into fibrinopeptides A and B. Fibrinogen consists of 3 pairs of polypeptide chains, alpha, beta, and gamma. Thrombin generation cleaves small portions of the alpha and beta chains, creating fibrinopeptides A and B. The remaining portions of the alpha and beta chains remain attached to the fibrinogen molecule. With fibrin peptides A and B cleaved, the fibrin monomer is created. These monomers spontaneously polymerize by hydrogen bonding to form a loose and stable fibrin network. Thrombin activates factor 13A and calcium, and then catalyzes the formation of peptide bonds between monomers, forming fibrin polymers that lead to an insoluble and resistant clot. Balance between the coagulation and fibrinolytic systems is crucial for maintaining circulation and for repairing injury. An overactive coagulation system could cause excess clotting. An overactive fibrinolytic system could cause hemorrhagic events. Several other components may play a role in hemostatic balance. Early studies suggest that decreased plasmin generation might decrease fibrinolytic activity in individuals with a high concentration of lipoprotein A. Because cholesterol and triglycerides are fatty components of lipoproteins, it is conceivable that reduced plasmin generating activity in individuals with increased levels of lipoprotein might lead to less clot dissolution, leaving clots available for a pathologic outcome. Disorders of fibrinogen. Appropriate levels of fibrinogen are necessary to maintain hemostasis and induce platelet aggregation. The reference range for fibrinogen is 200 to 400 milligrams per dl. Fibrinogen is also an acute phase reactant, meaning that fibrinogen increases transiently during inflammation, pregnancy, stress, and diabetes, and when a woman takes oral contraceptives. Evaluating a problem involving fibrinogen requires a careful patient history. For the most part, decreased fibrinogen is due to acquired disorders, such as acute liver disease, acute renal disease, or disseminated intravascular coagulation, or DIC. Acquired increases in fibrinogen may be apparent in patients with hepatitis, pregnant women, or individuals with atherosclerosis. Inherited fibrinogen disorders include afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia. These conditions are rare and, depending on severity, are marked by hematomas, hemorrhage, and ecchymosis. Afibrinogenemia, a homozygous autosomal recessive disorder where there is less than 10 milligrams per dl of fibrinogen in the plasma. This small amount of fibrinogen is usually not demonstrable by traditional methods. Infants with afibrinogenemia exhibit bleeding from the umbilical stump. Poor wound healing and spontaneous abortion are also features of this disorder. Lab results show elevated prothrombin time, activated partial thromboplastin time, or APTT, thrombin time, and repilase time. In addition, the results show abnormal platelet aggregation with most aggregating agents and elongated bleeding time. Cryoprecipitate and fresh frozen plasma are the replacement products used for medical management of bleeds in patients with afibrinogenemia. Hypofibrinogenemia, the heterozygous form of afibrinogenemia. This disorder is autosomal recessive, and patients exhibit 20 to 100 milligrams per dl of fibrinogen in their plasma. Patients with hypofibrinogenemia may have mild spontaneous bleeding and severe postoperative bleeding. Results of laboratory coagulation testing, whether prolonged or normal, depend on the amount of fibrinogen present. Dysfibrinogenemia refers to the fibrinogen disorders that are autosomal dominant and are inherited homozygously and heterozygously. Dysfibrinogenemias produce a qualitative disorder of fibrinogen in which an amino acid substitution produces a functionally abnormal fibrinogen molecule. Although these disorders are an academic curiosity, they are infrequently associated with a bleeding tendency. A few dysfibrinogenemias are associated with thrombosis. Approximately 40 abnormal fibrinogens have been discovered. Because the abnormal fibrinogen molecule in dysfibrinogenemia affects fibrin formation, most of the usual laboratory assessments for fibrinogen are abnormal. An immunologic assay of fibrinogen that measures the antigenic level of fibrinogen is usually normal. However, the PT, APTT, TT, and reptilase times increase. The clottable assay for quantitative fibrinogen is abnormal because this assay depends on the proper amount and proper function of fibrinogen. Multiple roles of thrombin in hemostasis. Thrombin is also important in the coagulation mechanism because of its multiple functions and the numerous reactions it mediates. The impact of thrombin is far-reaching, from the initial activation of the platelet system to the initiation of the fibrinolytic system and subsequent tissue repair. Thrombin is generated in small concentrations because of injury to the endothelial cells and proceeds to initiate a more enhanced coagulation mechanism. When generated, thrombin participates in the platelet release reaction and platelet aggregation. Secondarily, Thrombin stimulates platelets to produce the platelet inhibitor prostacyclin. With the coagulation system alerted, thrombin activates factors 5 and 8, key cofactors in thrombus formation. Thrombin also activates protein C, a naturally occurring inhibitor to coagulation. Protein C, acting along with protein S, combines with thrombomodulin, an additional product secreted by endothelial cells, to inhibit factors 5 and 8. Therefore, the clotting formation activity is diminished. Thus, thrombin is a procoagulant and key player in fibrinolysis. Fibrinolysis. The creation of a cross-linked fibrin clot is an essential element in the coagulation system. Equally important is the body's ability to remove the clot in a timely fashion. Essential to this vital system are proper levels of naturally occurring inhibitors, proper levels of fibrinolytic components, and methods to assess if these substances are in or out of balance. The following sections describe each of these components and their role in clot dissolution. Clot dissolution. A crucial link in the chain of hemostasis is the dissolution of fibrin clots, which usually occurs several hours after the stable clot is formed. Blood flow is restored at the local levels, and tissue healing is precipitated. The body provides naturally occurring or physiologic activators that initiate this process. The key component in this reaction is plasminogen, a plasma enzyme synthesized in the liver with a half-life of 48 hours. Plasminogen is converted to plasmin, chiefly through the action of tissue plasminogen activator, or TPA, which is released as a byproduct through the activity of endothelial cell damage and the production of thrombin. Additional activators include factor 12, kallikrein, and high molecular weight kininogen, or HMWK. Once produced, plasmin, a potent enzyme, does not distinguish between fibrin and fibrinogen and works to digest both. Plasmin also hydrolyzes factors 5 and 8, and if it circulates in the plasma as pathologic free plasmin, the damage to the coagulation system is significant because clots are dissolved indiscriminately. TPA has been synthesized by recombinant technology and is presently used for fibrinolytic therapy during stroke episodes. As a clot-busting drug, TPA has been effective in thrombotic strokes. If injected within 3 hours, it can prevent serious side effects of stroke. Another plasminogen activator is urokinase, a protease present in the urine and produced by the kidneys. The physiologic effect of urokinase is minimal in clot dissolution. However, similar to TPA, it is a valuable commercial product used in thrombolytic therapy for patients with heart attacks, strokes, and other thrombotic episodes. Streptokinase, an exogenous fibrinolytic agent, is produced when bacterial cell products form a complex with plasminogen, a pairing that converts plasminogen to plasmin. This toxic product has the most activity on fibrinogen. Naturally occurring inhibitors of fibrinolysis. Just as fibrinolysis is the balance to the coagulation system, inhibitors of fibrinolysis balance the fibrinolytic system from overconsuming. Products that restrain fibrinolytic activity aid the balance of hemostasis. These products, plasminogen activator inhibitor 1 and alpha-2 antiplasmin, act on different substrates in the fibrinolytic system. Endothelial cells secrete PAI1 during injury and suppress the function of TPA in the plasminogen-plasmin complex. As a substrate, plasmin is directly inhibited by alpha-2 antiplasmin in a 1-to-1 ratio at the target area. This inhibitor prevents plasmin binding to fibrin in an orderly fashion and is the most important inhibitor of the fibrinolytic system. Inherited deficiencies of this inhibitor invariably lead to hemorrhagic episodes resulting from an overactive fibrinolytic system. Secondary agents that can inhibit fibrinolysis include alpha-2 macroglobulin, C1 inactivator, and alpha-1 antitrypsin. As protease inhibitors, these substances act on thrombin formation. Because thrombin is one of the initiators of plasmid generation, the secondary effect on the fibrinolytic system is unavoidable. I'm going to go over this chart for thrombin and its roles, just because I think it'll help me. So thrombin stimulates platelets to platelet aggregation. It converts fibrinogen to fibrin. It converts plasminogen to plasmin. It converts protein C to activated protein C. And it promotes wound healing and tissue repair. Okay. Measurable products of the fibrinolytic system. Physiologic fibrinolysis occurs in an orderly fashion, producing measurable products that can be captured by laboratory assays. Specifically, the byproducts of an orderly fibrinolytic system are fibrin split products or fibrin degradation products, composed of early fibrin fragments labeled as X and Y, and late fragments composed of D and E. If D dimers are present in the plasma, it indicates that fibrin was formed and subsequently broken by the fibrinolytic system. At the present time, the measurements of early and late degradation products is used by fewer institutions. Once fibrin has been cross-linked and stabilized by factor 13, a stable clot has been formed. When this clot is dissolved by plasmin, D dimers are released. Excess D dimers indicate a breakdown of fibrin products within the circulating blood and at the site of injury. D dimer assays presently are used to assess thromboembolic episodes or deep vein thrombosis or pulmonary embolism. More than 600,000 Americans experience one of these clotting events. Originally, D dimer assays were designed such that monoclonal antibodies could pick up specific D dimer regions. These assays were time-consuming. Most assays are presently performed on sophisticated coagulation instrumentation using the principles of immunofluorescence, immunoturbidity, or chemiluminescence. D-dimer assays are particularly useful in monitoring thrombolytic therapy, as their presence indicates that fibrinal stabilized clots have been broken down. Conditions that may elevate D-dimers: disseminated intravascular coagulation, or DIC, pulmonary embolism, deep vein thrombosis, venous thromboembolism, coronary artery disease, infection, pregnancy, renal disease, malignancies, and trauma. Disseminated intravascular coagulation. The words "the patient has DIC" usually strike fear into the hearts of attending physicians, laboratorians, and nursing staff. An acute DIC event is almost always unanticipated, dramatic, and potentially fatal. DIC is triggered by an underlying pathologic event. During a DIC episode, the hemostatic system becomes unbalanced, hyperactivating the coagulation system, the fibrinolytic system, or both. This process leads to a systemic excessive deposition of thrombi and excessive hemorrhage. Additionally, the process is consumptive, destroying clotting factors and platelets as soon as they are activated for coagulation. The decrease in clotting factors usually overpowers the increase in lysis. In broad terms, DIC is associated with obstetric complications, malignancy, massive trauma, bacterial sepsis, asplenia, or necrotic tissue. Although most DIC events occur as acute, explosive episodes, some conditions may lead to a chronic compensated DIC state. These conditions are much more difficult to diagnose because the bone marrow and liver perform an excellent job of maintaining equilibrium between the coagulation and the fibrinolytic system. Laboratory results may be minimally abnormal, but an acute DIC episode is likely when the underlying pathology intensifies. Mechanism of acute disseminated intravascular coagulation. As is customary in normal hemostasis, the coagulation system and the fibrinolytic system are activated in parallel. However, DIC lacks the negative feedback mechanism that holds the system in balance. The DIC cycle is a composite of the following events. The release of excess thromboplastin triggers the excessive generation of thrombin, which triggers coagulation and fibrinolysis. Spontaneous enzymatic conversion of fibrinogen to fibrin occurs, which promotes clotting. Plasmin generation degrades fibrinogen fibrin into FDPs, promoting fibrinolysis and resulting in excess FDPs within the circulation. Excess FDPs degrade soluble fibrin monomers, resulting in anticoagulant effect. Plasmin causes inactivation of factors 5, 8, 11, and 12, resulting in anticoagulation. Platelet and clotting factors are coated with soluble fibrin monomers. In the presence of excess FDPs, the monomers are degraded and platelet and clotting factors are inactivated, leading to hemorrhage. Any clots that are formed are unstable, contributing to bleeding. Although the body attempts to minimize damage when a DIC event occurs, physiologic inhibitors such as protein C, protein S, and thrombomodulin are inactivated. Therefore, in DIC, although clot formation is hyperactivated, bleeding is the major result secondary to platelet and clotting factor inhibition, overactive factor inhibitors, and faulty fibrinolysis. Primary fibrinolysis. Primary fibrinolysis is a DIC-related disorder in which plasmin within the circulatory system is activated by sources other than thrombin. In this rare condition, plasmin acts indiscriminately on fibrinogen and fibrin, making hemorrhage inevitable. Because thrombin is bypassed, the platelet count is normal in contrast to the platelet count in DIC. All other parts of the coagulation profile in DIC are abnormal, however. There is controversy as to whether primary fibrinolysis is a disease entity or just a continuum of the vicious DIC cycle. Clinical symptoms and laboratory results in acute disseminated intravascular coagulation. In hemorrhagic episodes, most patients have extensive skin and mucous membrane bleeding, included ecchymosis, epistaxis, and petechiae. Because entry sites such as surgical incisions, catheters, or venipuncture may ooze, they must be carefully observed. In thrombotic episodes, patients may exhibit acrocyanosis, hypotension, or shock. Microthrombi may occur in the nose, genitalia, or digits, or in major organs, such as the kidneys, liver, or brain. As mentioned previously, acute DIC is a medical emergency. The entire basic coagulation profile in DIC is abnormal. PT and PTT are prolonged. Fibrinogen and platelets are decreased, and FDPs and D-dimers are dramatically increased as stable clots are broken down. D-dimer results are an essential piece of data in patients with emerging DIC. However, other pathologies such as inflammation, renal disease, or local clot may elevate the result. For this reason, all laboratory data must be carefully reviewed in concert with clinical symptoms before reaching the diagnosis. Not all patients with DIC have decreased fibrinogen levels. Studies have shown that clinical outcomes are much poorer for patients exhibiting DIC with near normal fibrinogen, often resulting in severe organ failure. During a DIC event, the coagulation profile is abnormal. The PT is increased due to inactivation of clotting factors. APTT is increased due to inactivation of clotting factors. Platelets are decreased due to the platelets being consumed. Fibrinogen is decreased due to increased activity of plasmin, and D-dimer is increased due to rapid degradation of fibrin-stabilizing clots. Recovering patients should be monitored over time using the same initial profile for comparison and evaluation of their coagulation status. Patients develop microangiopathic hemolytic anemia secondary to microthrombi disposition in the small vessels. Schistocytes are observed as a morphologic marker for this process. Treatment of acute disseminated intravascular coagulation. Identifying the precipitating event that led to DIC usually results in successful treatment that resolves this pathology. Surgery for obstetric complications or widespread use of antibiotics for septicemia may stem the bleeding episode. Because many clinicians are perplexed about the root cause of the precipitating events, however, blood products can be used judiciously to stop the bleeding. Fresh, frozen plasma is a source of all the clotting factors. Packed red blood cells restore oxygen carrying capacity, and platelet concentrates enable clot formation. Heparin has been used in DIC cases when combined with antithrombin. Although controversial, this agent may provide needed antithrombin activity to delay excessive coagulation. Condensed case. A 20-year-old woman came to the emergency department with unspecified complaints. A CBC was ordered and her platelet count was recorded as 17 to the times 10 to the 9th per liter. A repeat sample was ordered and the platelet count was recorded as 6 times 10 to the 9th per liter. The results failed to delta check because an admission 3 weeks prior listed a platelet count of 250 times 10 to the 9th per liter. The technologist called the physician immediately with the report of the thrombocytopenia and the discrepancy in results and inquired about the patient's history. The first step is to check the specimen for clots. Improperly mixed specimens are notorious for containing small clots. Emergency department personnel may be unaware that lavender top tubes must be inverted at least 5 times for proper mixing. Light blue top tubes, 3.2% sodium citrate, are used for coagulation studies, but the platelet count in the aforementioned CBC is almost always done using a lavender top tube, or ethylene diamine tetraacetic acid, or EDTA. The specimen was checked and no clots were observed. Next, the technologist queried the physician as to whether or not this was an expected result. The physician revealed that the patient had undergone a cardiac procedure and that the initial consensus was that the thrombocytopenia was induced by medication. The patient was admitted and transfused with platelet concentrates, and the platelet count increased to 56 times 10 to the 9th per liter. No additional history is known at this time. Summary points. Fibrinogen is the key substrate of the coagulation and the fibrinolytic systems. Fibrinogen has the highest molecular weight of all the clotting factors. Thrombin acts on fibrinogen, converting it to fibrin. Stabilization of fibrin by factor 13 and calcium results in an insoluble clot. Plasminogen is converted to plasmin primarily through tissue plasminogen activator and then proceeds to destroy the fibrin clot. Afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia are all inherited disorders of fibrinogen. Each of these may also be an acquired disorder. Naturally occurring inhibitors of fibrinolysis are plasminogen activator inhibitor 1 and alpha-2 antiplasmin. The byproducts of fibrinolysis are FDPs and D-dimer. D-dimers are produced from a cross-linked and stabilized fibrin clot. Excess D-dimers indicate excessive lysis of cross-linked and stabilized clots. DIC is usually triggered by an underlying pathologic event. Patients with DIC excessively clot or excessively bleed, or both. Laboratory results for a patient with acute DIC show prolonged PT and PTT, decreased fibrinogen and platelets, and increased FDP and D-dimers. Treatment for DIC includes investigating and resolving the cause of the disorder and providing blood bank products as needed. Case study. A 27-year-old man was brought to the emergency department in serious condition. Earlier in the day, he was hiking and had been bitten on his leg by what he thought was probably a black snake. His leg was swollen, and he was extremely lethargic and barely conscious. Additionally, he was bleeding from the site of the wound. When blood samples were drawn, the venipuncture site bled profusely. His laboratory results are platelets 27 times 10 to the 9th per liter. PFA, or platelet function assay, was not performed. PT of 21.2 seconds, with the reference range being 11.8 to 14.5. PTT was 53.7 seconds, with the reference range being 23 to 35. Fibrinogen 110 milligrams per dl, with the reference range being 200 to 400 milligrams per deciliter. D-dimer, 3,170 ng per ml. D-dimer units, reference range 0 to 200 ng per ml. The patient's base coagulation profile was abnormal. His PT and PTT were markedly prolonged. His platelet count was markedly decreased. His fibrinogen was decreased, and his D-dimer was abnormal. DIC was triggered by the snake bite. Because the venom of poisonous snakes directly activates factor 10 or factor 2, clotting occurs at an accelerated rate within the vessels, consuming all the clotting factors. The D-dimer result is extremely elevated. D-dimer is the smallest breakdown product of fibrin. When elevated, it is indicative of cross-linked fibrin within the circulating blood rather than locally at the site of injury. The patient was given antivenom and supported by blood products until his condition stabilized. Review questions. One of the key roles of thrombin with respect to fibrinogen is that it converts fibrinogen into fibrin. In a patient with dysfibrinogenemia, a normal laboratory assay would be immunologic assays for fibrinogen. The reptilase time, thrombin time, PT, and PTT would all be abnormal. 3. The primary purpose of the fibrinolytic system is to restore blood flow at the local level. 4. The bacterial cell product that would precipitate a DIC event is streptokinase. 5. The best possible treatment for a patient with DIC is to resolve the underlying cause. 6. The process of fibrin degradation is called fibrinolysis and is controlled by the enzyme plasmin. 7. A prolonged thrombin time and a normal reptilase time are indicative of heparin therapy. 8. The functions of thrombin are initiating the platelet release reaction, stimulating platelets to produce PGI2, activating factors 5 and 8. 9. D-dimers may be elevated in deep vein thrombosis. 10. A primary inhibitor of the fibrinolytic system is alpha-2 antiplasmin.